my talk today about a very difficult scenario when you lose the artery without wire protection. Actually, this 45 years old Indian male patient, no history of dyslipidemia, previous PCI 4 years ago in India, but no report. Typical chest pain for 6 hours, troponin 0.5 on presentation, echo LVAF 40% with all motion abnormalities, and echo moderate MR, ECG infralateral wall T-wave inversion. And we take the patient to the cath lab, showing there's CTO in the mid LCX actually, and the proximal lesion very tight to the CTO segment with ipsilateral collaterals from the diagonal branch and LAD branch. And this is the LCX actually, very tight lesion. So we consider this is a culprit for presentation of this patient, very tight RCA. And I did the RCA predilatation, then stenting 315, and then BDA also, there is lesion. So we deploy stent in BDA for this presentation. Patient presented to us after 2 months. Actually, he missed follow-up for some issue. We are governmental hospital, so appointment was difficult to come back after that. So we plan for CTO PCI of this mid left circumflex artery. And this is the dual injection from the RCA, showing a very long segment of the mid left circumflex. I'm using antegrade approach with fielder FC wire with a small balloon support, 1.5 balloon. And I successfully crossed the lesion with this balloon actually, and started to dilate the CTO segment. And I decided to use the same balloon to dilate this very tight lesion proximal to the CTO segment actually. And this after I using the balloon. There is abrupt vessel closure with hematoma in this proximal segment and losing of the OM branch, which is very big actually, without any wire protection in the OM branch. Patient having bradycardia, we give atropine and try to stabilize. This is the OM before we dilate the proximal lesion actually. So what happened? Actually, just a few seconds, the nurse told me, Dr. Kasem, the balloon ruptured. So the question for me is this 1.5 balloon can be ruptured for this very tight lesion? Actually, the answer coming from many data that even spicules and even small balloon can be ruptured when there is heavy calcification from calcium spicules that cut the balloon itself, and can causing even dissection with total occlusion like our case, and hematoma, mural hematoma in the wall in this case. So I know the underlying etiology, there is dissection, but the challenge for me, there is no wire in the OM, so I cannot pass to this big OM actually. So I try to use a second wire actually, BMW wire, but it is difficult, wire cannot pass, and I using a small balloon again in the first wire to make inflation. Also there is no improvement in this lesion. And I decide to use what I call it the body balloon technique. So I inflating the balloon, then after deflation, immediately I try to pass the wire besides the balloon, but also failed to cross this situation. So I used to use bigger balloon for the initial wire actually. And I noticed there is some partial improvement after larger balloon used in this setting. So, but the wire trial again after this partial improvement still failed to cross to the OM branch. So I decided to use prolonged sustained inflation of the balloon for 5 minutes, 16 atmospheric pressure for 5 minutes persistent, and immediately after 5 minutes there is gaining of the flow for this big OM, and successfully wiring of this big OM, and I make more dilatation and optimization of the lesion and securing of the patient become stable after we gain the flow. And after that I decide to start with bailout stenting for the proximal LED actually, and this is after deployment of the stent for proximal LED with the OM branch. Then I make rewiring for the CTO segment of the mid circumflex, and after crossing with ballooning and then optimization with balloon of the strut of the stent, and this is after optimization of the CTO segment. And I decided to use what I call inverted tab technique with balloon protection in the main vessel and then optimization the position of the stent in the mid circumflex. Of course, the proximal stent edge at the level of the proximal ostium border, and then stent deployment. Then I pull back the stent balloon and make kissing balloon for the bifurcation lesion, and then final put proximal to the lesion actually, and this is the final results after we deploy two stent bifurcation technique and saving the OM branch in this case. And this is the final results. We notice the bifurcation angle of left mean. It is difficult angle actually, and very wide angle, cannulation, wiring, all not easy for this case. And this is the final results. So abrupt vessel closure, either we know the underlying etiology or we don't know the underlying etiology. If we don't know the underlying etiology, we should using microcatheter, perfusion catheter, and inject contrast distal to the occlusion site so we can differentiate between neuroflow phenomena or dissection. Or if we know the mechanism, dissection, thrombus in situ formation, neuroflow, air embolism, or vasospasm, we can treat accordingly. So final take-home message: abrupt vessel closure without air wire protection is real nightmare. Timely recognition the underlying mechanism of abrupt vessel closure is crucial for early treatment and control of this life-threatening complication. Keeping the guide wire in its place is a cornerstone to treat abrupt vessel closure due to dissection. Prolonged balloon inflation is necessary in some cases to facilitate second wire crossing to distal true lumen of side branch, and partial make sealing of the flap. Bail-out stenting is the fastest feasible option to seal dissection flap and reopen the artery. And a very important statement: calcified lesion proximal to CTO segment should be well prepared and balloon dilated and stented even prior to proceed for the distal CTO segment. Thank you.